Thank you, Angie. And welcome, everybody, and good afternoon. I'm going to be moving along at a rapid clip today because we have a lot of material to cover. So just keep in mind that you can ask your questions in the chat box, and there will be some time for Q&A at the end as well. So we're going to be covering several different tests today. We're going to start out with hormones and in saliva. And we're going to talk about cortisol, melatonin, sex hormones. Then we're going to move on to our HuMap, urinary metabolite hormone testing. Then we'll move on to neurotransmitters, methylation, our GI 360, the cardiometabolic profile, and metals. So we're going to start with the tests that are available to test in saliva, specifically cortisol. But first, let's talk a little bit about the advantages of saliva testing in general. Because steroid hormones have a cholesterol fatty base, they remain unbound by protein carriers, which allows measurement of these free bioavailable hormones in saliva. Unlike serum, where the hormones are attached to sex hormone binding globulin or albumin, a protein carrier, and they require a calculation to measure the free portion, which is only about 3 to 5% of total hormone. Saliva can directly reflect that 3 to 5% of what's biologically active. It's also the most accurate way to monitor topical or transdermal therapy because it reflects tissue absorption. And it's also considered the gold standard for assessing the diurnal cortisol curve and for the cortisol awakening response. The adrenal phasing is a way to categorize the degree of HPA axis dysfunction. It can help guide your treatment protocol. Because morning cortisol is reflective of overall HPA axis responsiveness and adaptation, we base our phasing on that AM30 level. Whenever you see an upper range AM30 or even an upper range or elevated cortisol level anywhere in a curve, that's going to be phase 1. Phase 2 is evolving HPA axis dysfunction, and phase 3 reflects long-term HPA axis adaptation to stress. So this is a pretty typical picture that you'll see in a patient who's experiencing ongoing stress over years. You'll see this higher level in the beginning, and then you'll see it start to adapt by becoming lower, and then finally, oftentimes there'll be a flatlined picture after many years. And here's our treatment consideration guide, depending on those phases. You'll see lifestyle modification suggestions for each phase, as well as nutrient and herbal suggestions based on each one. And when assessing HPA axis, when should you run the HuMap and when should you run saliva? Well, cortisol has two functions: proactive, so it provides a diurnal rhythm to instigate waking up and preparing for the day. And it also has a reactive function where it releases cortisol as part of the stress response to adapt to perceived stressors. Saliva is reflective of individual points in time in a diurnal rhythm, whereas urine better reflects a reactive cortisol spike since the last void or the overall cortisol load. And we'll see some better pictures of that coming up. And these are some examples of how stress might present in two different media. On the left, you see a patient, same patient in a 24-hour period. So if you only looked at the saliva graph on the left, you might think that this patient needs some hydrocortisone supplementation as she's nearly flatlined. And we'll see this pattern as suggested, as I already talked about, over long periods of prolonged stress. Yet for this very same patient, her urine results on the right paint a very different picture, reflecting her cortisol load since her last void. So when we see these elevated levels upon waking, these are reflective of overnight spikes in cortisol. So then we're thinking about, well, what's causing that? What kind of sleep interruption was taking place? Is it a hygiene issue? Is there insufficient darkness? Was there interruption, frequent wakings? Is this person have sleep apnea? Are they sleeping with somebody who snores? So what's nice about the urine is that we're catching the stress with the pooled sample, whereas that saliva is going to give us a picture of HPA axis capacity. The cortisol awakening response, or the CAR, gives us another view of cortisol in saliva. So here we're looking at, on the left is just that 4-point cortisol graph, and on the right, you're looking at the cortisol awakening response. And you'll see that there are 2 additional vials added to the cortisol awakening response for AM0 and AM60. So you can add this cortisol awakening response to any saliva samples. It's, as I said, it's only 2 additional tubes, or you can order it as a standalone test of 3 tubes, and this is what you'd be receiving right here. So many providers will include it with their first cortisol test of their patient so that they can get a baseline. So the CAR can provide additional information about overall HPA axis responsiveness and function that might not be seen in the original diurnal cortisol profile. So for example, in this profile here, we're seeing that the AM60 is the highest point of the morning when it should be AM30. So what I recommend providers do when they're reading these reports is to look at that green shaded area, because that's the optimal zone or the functional zone. And so you can see how your patient's results compare. So when we see this high cortisol reading somewhere in the cortisol awakening response, we're wondering about what kind of anticipatory stress might be going on for that patient, and then you can address treatment accordingly. So how do you interpret the CAR? So in this example, it's a little confusing because you see that the rise is low and the decline is elevated. What does that mean? So the rise, again, if you look at the green shaded area, that's telling you where you should be focused. The rise should be at the AM30, right? So in this case, the rise is between the 30 and the 60. So the rise is low. And the decline should be between the 30 AM30 and the 60. But in this case, there is no decline. There's an elevation. So the decline is high. And we can help you wrap your brains around that, because I know it's confusing in the beginning. So let's talk about melatonin, which can also be measured in saliva. So what if your patient has trouble falling asleep, but their melatonin is high at night? That just doesn't make sense. Well, the most common reason for a pattern like this is recent supplementation with melatonin or even 5-HTP. Also, SSRIs and SNRIs could be involved, or consuming for foods that contain tryptophan or phytomelatonin. And I just saw this pattern the other day when I was on the phone with a provider, and it seemed to be related to an unusually early 4:15 a.m. wake up, when that patient usually wakes up later. And it was followed by a very late bedtime of 1:45. So in both of these cases, we would expect the melatonin levels to be elevated because normally that person would be asleep. So the diurnal rhythm is doing what it's supposed to do in terms of having melatonin elevated. Lack of light in the morning could play a role in not suppressing melatonin. And lack of darkness at night could, opposite. Too much, no. Apologies. If you see an elevated melatonin, as we were talking about at night, it's most likely because of other kinds of supplements that have influenced them. So it's most likely not due to their melatonin levels being low if they're experiencing insomnia or elevated. Sorry, that was just not very clear. I'm going to do that again. If melatonin is high at night and the person is not sleeping, then the problem isn't likely to be melatonin. It's probably related more to some sleep hygiene issues or supplementation. Elevated melatonin can be addressed with morning exposure to sunlight or a full spectrum light box, which will suppress it, or more time outside during the day. Even in a gray or rainy weather, there's more full spectrum light than indoor lighting. Also consider neurotransmitter testing to rule out serotonin, because serotonin can convert to melatonin. So in terms of testing sex hormones in saliva, here's a depiction of our comprehensive saliva hormone profile, where we're testing all 3 estrogens, E1, E2, and E3. We're looking at the estrogen quotient ratio, as well progesterone and the PGE2 ratio. Both of these ratios are going to help approximate risk of proliferative issues and to help target supplementation to minimize that risk. So the EQ has a reference range for women only, so you really don't need to run the EQ in men, while the PGE2 is relevant to both women and men. So when there are sufficient quantities of estriol, which is a protective estrogen, as indicated by an EQ of greater than one, in this case, you see the patient's result is 1.5, which is optimal. It can help to antagonize the proliferative effects of estrone and estradiol. We want it to be above 1. The PGE2 ratio provides information to help address progesterone insufficiency, which is valuable for protecting breast, heart, and bones in women and for prostate health in men. The PGE2 ratio was developed by Dr. John Lee to quantify progesterone insufficiency relative to estrogen. In men, a healthy ratio is associated with a lower risk of prostate symptoms and cancer. And in women, a healthy ratio reflects breast, uterine, heart, and bone protection and is associated with relief from progesterone insufficiency symptoms. Because estrogen is proliferative and progesterone is differentiating and is going to counterbalance the effects of estrogen. For estradiol and progesterone, why is the supplementation range higher than the reference interval? Again, our supplementation ranges are based on the work of Dr. John Lee, and they reflect a healthful, youthful endocrine glands output. Dr. Lee tracked thousands of patients' response to treatment, and he found that it was within these ranges that symptoms and bone density improved. And his data has been validated by our database of over 180,000 processed saliva test kits. So if you're planning to prescribe hormones, it's really important to understand the differences between progesterone and progestins. So here you can see bioidentical progesterone on the left and a progestin on the right. The bioidentical progesterone shares the molecular structure with what's produced endogenously in the human body, whereas the synthetic progestin on the right has a slightly different molecular structure. So it's going to lead to different physiologic effects. When one tests while on a progestin-based birth control, it's going to show you how that contraception is affecting hormone balance, which tends to be very predictable because of how progestin suppresses ovulation. And it's going to lead usually to progesterone insufficiency and potentially to low-range estradiol and suboptimal testosterone. Because we can't measure progestin in our laboratory test system, the results are going to reflect suppressed production of progesterone. A progestin-based IUD, such as the Mirena, is a slightly different mechanism because it thickens cervical mucus and it inhibits sperm movement and viability. So you may see normal or low-range estradiol and progesterone even on a hormonal IUD. So a couple more questions related to saliva collection. So how long to wait after the last hormone dose before collecting saliva? This is really important. And it's one of the reasons that saliva testing is often misunderstood. It's really important that your patients understand this. So if somebody's on topical hormones, it's going to be a 12 to 24 hour in between their last use and when they start collecting samples. When they're using a sublingual hormone or a troche, we're looking for a 24 to 36 hour window. And it's really important that they drink a couple glasses of water afterwards. That might seem kind of silly and obvious, but you'd be surprised how important that is and how in drier mouths, those molecules can really stay in the mouth. With oral hormones, they should be used and prescribed as normal. So even on the day of collection is fine. A lot of people are on progesterone that they're taking at bedtime the night before. That's totally fine. And then injections, subcutaneous pellets, and transdermal patches, we're really trying to catch it in between their doses. So if somebody changes their patch weekly, we want them to test somewhere between, ideally 3.5 days. So somewhere between the 3 and 4 day mark. And this is another really important piece of making sure you're going to get accurate results depending on your patient's mode of delivery of hormones. So here we're looking, this patient is on a topical patch. And remember, we really want to see we want them to collect in between. And this is somebody who's on a twice a week patch, and they've got a 37 to 37 to 72 hour interval. So this is a long interval and you will not get accurate results. With the estriol, this patient is on a topical cream, and that should be a 12 to 24 hour interval, but the patient checked the box for less than 12, so they're likely to have elevated results. And with the oral progesterone, that one's right on because the oral can be taken anytime. Even though the patient took it less than 12 hours, that's fine. And this is a valuable graph to show when to collect based on one cycle pattern. We get a lot of questions about this. When somebody has an approximate 28-day cycle, we're looking at testing around day 21, give or take a day or two, give or take 2 days. If somebody has a longer cycle, greater than 28 days, you're going to count back 7 to 9 days from when they usually start to bleed. With ovulation pains, you can collect about 7 days after ovulation. With short cycles that are less than 14 days, you want to collect on day 7 to 9. If it's an unpredictable or infrequent cycle, after day 14 and before day 1 of the next cycle or before day 1 of bleeding. And if there's no reference point, which is often the case with perimenopausal women, we recommend collecting the sample, putting it in the freezer for 2 days. And if after those 2 days, she hasn't bled, then she can go ahead and send them in. And if she does bleed within those 2 days, we recommend just rinsing the tube out with warm water, air drying it, and then trying again the following month. So let's talk about urine hormone testing, our HuMap test. The HuMap is a comprehensive look at hormone metabolism, including 2-OH and 4-OH estrogen pathways and key enzymes like 5-alpha reductase and 17-beta HSD. Because it uses liquid urine, it captures low concentration metabolites with higher sensitivity than dried urine. It's non-invasive, it's easy to collect over a single day, and it can even be paired with a neurotransmitter add-on. It also includes the oxidative stress marker 8-OH-DG. So in terms of which clinical conditions you might be thinking about for HuMap, in female health, it can be it can be very beneficial for assessing menopausal symptoms, PCOS, endometriosis, PMS, PMDD, and breast health. For male health, erectile dysfunction, prostate health, and loss of muscle mass, the HuMap can be beneficial for. And just for general health, it's great for helping to identify metabolic syndrome, thyroid pathologies, inflammation, oxidative stress, fatigue, insomnia, and libido concerns. And as I mentioned, we've got the oxidative stress marker 8-OH-DG as well. Saliva is the best option when you want tissue-level hormone activity, especially for PMS, perimenopause, menopause, and monitoring transdermal therapies or diurnal cortisol patterns, including the cortisol awakening response. And urine is the best option when you need metabolic data. So we're looking at metabolites. So anytime you want to see metabolic data and insight into enzyme activity, like aromatase or 5-alpha reductase, or when looking for inflammation. As well, overnight cortisol secretion is reflected and might give you an indication of how lifestyle and stressors are going to affect cortisol output. So this is page 2 of the report. It's your patient's entire hormone map, and it's all heat mapped by their particular results and color coded according to their results. So you'll see the blue, the dark blue is low, the light blue is low range, but still within the range. Optimal is green, upper range is yellow, and above range or abundant is red. There we go. So several things make the HuMap unique, and this is that front page summary of key ratios and clinically relevant analytes. So because the samples are from wet liquid versus dried urine, there is no need for reconstitution. So that enables direct measurement of creatinine. So let's just do a quick overview of this front page here. You've got your estrogen metabolites, including the methylation products here. As well, we're looking at the ratios of 2-OH to 4-OH and 16-OH. So that's what these gray bars are. You're looking at cortisol and how it compares to cortisone. Cortisol is still active as a metabolite, whereas cortisol is inactive. And then we're looking at all the different enzymes and enzyme activity below here. And you can see, whether one is having a preference for one or another enzyme. Some of the clinically relevant findings that you might find on your HuMap, such as excess aromatase or 5-alpha reductase and how they might impact androgen balance. In men, that's going to lead to the 5-alpha reductase activity. The aromatase activity is going to lead to depletion of testosterone. And in women, it's going to contribute to symptoms of androgen excess. Low progesterone in premenopausal women suggest anovulation. And in men, it can reflect prostate health. An elevated 8-OH-DG indicates oxidative stress and estrogen issues such as phase 1 imbalance between metabolites, poor methylation. It's also going to reveal the cortisol patterns like elevated morning cortisol, cortisol-cortisone imbalance, and overall abnormal excretion. Clinically, the HuMap is going to give you a window into how the hormones are being metabolized and moved out of the body. It gives you a view into phase 1, phase 2 estrogen detoxification. The ratios are going to indicate that enzyme activity, and it's going to allow you to see certain patterns of imbalance that are associated with higher risk of hormone-driven cancers. It's also a great starting point for determining nutrient, herbal, and lifestyle recommendations to support the enzymes of detoxification pathways. It can also reveal patterns of metabolism-related health conditions, such as hypo or hyperthyroid, insulin resistance, and inflammation. So in the next couple of slides, I'm going to show you how the treatment guide is going to give you some different views of suggestions for dietary and nutrient support. So we're going to focus on the estrogen neighborhood on the right. This is in a 68-year-old male who's taking testosterone. You can see in this neighborhood here that he's aromatizing to estradiol and estrone from testosterone and androstenedione, which are within range. I want to draw your attention to the circles on the right, especially how they relate to the treatment guide. So the COMT enzyme here. So while the entire estrogen neighborhood is hot with aromatization, we're going to be focusing on methylation, specifically at the 2-OH and 4-OH pathways and where methylation is taking place via that COMT enzyme. So continuing with this case, on the left that you're seeing a view from our therapeutic considerations guide, and on the right, this is the cover page of the therapeutic considerations guide. On the prior page that we saw some need for supportive phase 2 detoxification, and here you see some research-based suggestions on how to support COMT using food, spices, and nutrient cofactors. We put a lot of blood, sweat, and tears into this therapeutic consideration guide. So I recommend that you use it while you're going through your patient's results. Here's another view of the entire pathway chart that's color-coded specifically by each individual enzyme. And here are those enzymes. Another view of supporting or suppressing. Here we're looking at aromatase, which we want to suppress or modulate. We want to decrease 4-OH estrogen in this patient. We want to address phase 2 detoxification, and we want to support 2-OH estrogen, which is protective. And here's one more view. And again, with the color-coded enzymes, I think it's really nice to have all the different options. It's just something for every brain here, as some people are linear and some are more color-based, some like more of a decision tree. So they're all those options are here. So now let's move on to neurotransmitters, which is also a urine test. It's a very common misconception that neurotransmitters only act in the brain. In reality, they're chemical messengers of the autonomic nervous system with receptors throughout the entire body. They're produced and used in both the central and peripheral nervous systems, and they're catalyzed by the same enzymes everywhere. So while we can't measure the synaptic levels without a spinal tap, the urine is going to reflect whole body production, and it correlates well with symptoms. So if you're questioning this, just remember that 80 to 90% of serotonin is produced in the gut. The neurobasic test is what you see here outside of the green area. Serotonin, dopamine, norepinephrine and epinephrine, glutamate and GABA, histamine and glycine. And then the comprehensive neurotransmitter profile adds on everything that you see here in the green areas. So all these metabolites, as well as the amino acids, tyrosine, tyramine, and taurine. So which test should you pick for your patient? Well, both tests are going to help you to evaluate for deficiencies or excess levels, and they can help to illuminate the need for certain nutrient cofactors, which is a nice way to open the door to working on nutrition. And I'll back up there so you can see all those nutrient cofactors in red. The comprehensive profile also allows you to see, again, that metabolism picture, which is going to give you some information about MAO and COMT activity. So can you test patients who are using psychotropic drugs? Yes, and we encourage this because we really want to see how the medications are impacting pathways. The one caveat is that AM morning medication should be taken after sample collection because it's hard to predict results based on medication. We often see low and low range serotonin levels even in these patients. And sometimes we see low norepinephrine in patients taking SNRIs. So research shows that long-term use of SSRIs leads to depleted serotonin levels. So we do see that sometimes. So keep your patient on their psychoactive medications to run neurotransmitter testing. Creatinine is not diagnostic. It's used as an indicator of urine concentration. It doesn't have a diagnostic value, and it's not an indicator of renal function. Lower levels are going to indicate a more dilute urine, whereas higher levels are a more concentrated urine, and the results are calibrated according to your patient's concentration. And if they're too dilute, they're going to be discarded by the lab, and the provider will be notified. And here's the support consideration. Here's a page out of the support consideration guide for neurotransmitters and your handy-dandy QR code. Methylation testing is a great follow-up to neurotransmitters. So we're going to change gears here, and we're going to be talking about some new collection media, blood, and a cheek swab. So the DNA methylation pathway here on the left is a buccal swab, and it's a genetic test to identify single nucleotide polymorphisms, or SNPs. It's a genotypic screen, a snapshot of some inherited variants that might predispose one to inefficient methylation or altered biochemical pathways that may show up in methionine metabolism, detoxification, neurotransmitter balance, hormone regulation. We'll get to that. The plasma methylation profile is a dynamic expression of methylation capacity, showing real-time metabolites. Ultimately, it's showing that phenotypic expression of how SNPs might be expressing, which can signal the need for nutrient support, and it's a great way to monitor and guide therapy. So while genetic testing reveals potential, methylation testing shows how those genes are influencing functional markers. Impaired methylation can elevate homocysteine and increase cardiovascular risk, especially in those with an MTHFR variant. It can also disrupt neurotransmitter metabolism, contributing to mood disorders, ADHD, and other neuropsychiatric conditions. It can also weaken detoxification pathways of metals, estrogens, and xenobiotics. It plays a role in reproductive health by impacting hormone metabolism, infertility, and impacting miscarriage. And it can contribute to cancer risk by altering gene expression, as well as autoimmune disease through loss of immune tolerance. And here we're just looking at sort of that bigger picture of the methylation profile in plasma, reflecting that real-time function. So this diagram is showing phase 1 of the methylation cycle, that upstream portion where methionine is converted to SAM, which is our primary methyl donor. So that SAM then donates methyl groups for vital processes like neurotransmitter synthesis, gene expression, and membrane formation. And after it donates that methyl group, SAM becomes SAW, or S-adenyl homocysteine, which is then converted into homocysteine. At this point, homocysteine becomes a crossroads metabolite because it can either be remethylated, Oops, sorry. Got a little excited with my mouse there. It can be remethylated to methionine, or it can enter the transsulfuration pathway, which is shown at the bottom of the diagram here. And so we're also at what you're not seeing here is where cysteine converts into glutathione, which is our body's most important antioxidant. So you're not seeing it, but it is the next step downstream. What we don't want is for the cycle to get stuck at homocysteine and not make its way back up to methionine or down to cysteine and glutathione. The SAM-SAW ratio is a functional marker of methylation capacity. SAM, our universal methyl donor, and SAW, the byproduct of that can inhibit methylation when it accumulates. So dividing SAM by SAW gives us the methylation index. A low ratio suggests global DNA hypomethylation. It can also reflect oxidative stress, higher homocysteine, and SNP-related impacts. A higher ratio, which is desirable over greater than 4, indicates strong methylation potential and adequate methyl donors to support DNA repair, neurotransmitter synthesis, and phospholipid metabolism. So here you're seeing SAW is running elevated. It's a potent competitive inhibitor to SAM, largely due to its structural similarity because of that universal methyl donor group. When methylation reactions proceed, SAM donates its methyl group and it's converted into SAW, as we saw in the previous slides. And if that SAW accumulates, it's going to block further methylation reactions. So this is an undesirable ratio because it's less than 4. We really want to see it above 4. The DNA methylation buccal swab test evaluates key genetic SNPs, especially those that govern how well we produce and recycle methyl groups. It includes well-known genes like MTHFR, MTR, MTRR, and BHMT, which are going to affect how efficiently we convert folate and B12 into usable forms like methylfolate and methylcobalamin, as well MAO and COMT that regulate neurotransmitter breakdown, and COMT for phase 2 methylation. So when somebody is homozygous for MTHFR C677T, as you see here in this result, that could contribute, it could impact methylation by approximately 60%. And then when someone is heterozygous, it's going to impact methylation approximately 40%. So this can be a really valuable tool in that bigger picture. So now we're going to move on to our flagship stool test, the GI 360. So if you're deciding which stool profile to begin with, the GI 360 is the most comprehensive place to start. It captures pathogens, microbiome patterns, stool chemistries, and treatment sensitivities all at once. And we consider this our gold standard. The other tests are also excellent, but they're not as comprehensive, and they're more targeted for follow-up and retesting for specific concerns such as parasites or pathogens. For a baseline assessment, the GI 360 is going to give you the most comprehensive picture. We're often asked to summarize the differences between PCR and culture-based testing. PCR detects DNA in the bacteria, as well as viruses and parasites. It's fast, it's sensitive, it's reproducible, and it's very specific, while culture represents live organisms such as bacteria and yeast, which enables sensitivity testing for antimicrobial and antifungal medications and natural agents. So when we say culture, we're referring to the multi-TOF technology, which identifies with 100% specificity the genus and species of bacteria, fungi, and yeast. It's what's being used when you're seeing bacterial and fungal cultures, susceptibility testing, and microbiology cultures. So we're going to very briefly run through a sample report, starting with this front summary page, which is giving you a bird's eye view of your patient's significant GI 360 findings. If you only had 30 seconds to understand your patient's microbiome, this is the page that you would look at. So the colorful hexagon in the upper right is showing microbial abundance and balance across the 6 major phyla of a normal biotic microbiome in a healthy person. So the white shaded area represents the patient's results. So any results that fall inward are representative of insufficiency, and those that fall outward are, abundance or too much. Next, the dysbiosis diversity index comes specifically from that microbiome profile. A DI of 5 means that the microbiome is significantly shifted away from a healthy pattern. You want a lower number. So while a diversity score of 3 indicates less than optimal species diversity, you want to see a higher number of diversity and a lower number of dysbiosis. Below that, the GI health markers and key findings call out the highest priority issues. So whether on balance, the bacteria are protective or inflammatory, or if there's key pathogenic bacteria, what's going on with butyrate and secretory IgA production, and any pathogens or overgrowth that need clinical attention. The rest of the report breaks all of this down in detail, but this page tells you the story at a glance. Is the microbiome balanced? Is it diverse? Is it inflamed? And what organisms are immediately standing out? The microbiome bacterial abundance section shows the beneficial organisms detected by PCR, over 300 species across 6 major phyla. It gives you a baseline sense of microbial diversity and abundance and or pathology. And this is the pathogen screen. It's PCR based, so it's highly sensitive and specific. This section quickly flags the clinically relevant bacteria, virus, and parasites, even if they're only present at low levels. And now we're looking at the parasitology microscopy, which is divided by protozoa, cestodes or tapeworms, and trematodes or flukes, as well as yeast, RBCs, white blood cells, muscle and vegetable fibers, and even pollen detection. In the microbiology culture section, we're looking at which aerobic and anaerobic bacteria and yeast are growing, as well as their abundance. And then the yeast and bacterial cultures are tested against natural agents and pharmaceuticals to show you which antimicrobials that specific organism is sensitive to, or sensitive to for treatment or resistant to. And here's the individualized sensitivity panel for a specific organism. In this case, it's Klebsiella oxytosa, and it's highlighting which agents are most effective for this patient. So this is especially useful in patients when symptoms have persisted or that they've been resistant to other agents in the past. And you can also see the low sensitivity as well, so that you can see that the Klebsiella is not sensitive to the agents in blue. The stool chemistry markers give you a snapshot of the gut terrain. Elastase reflects pancreatic enzyme output. The fat stain screens for malabsorption. Elevated lactoferrin and lysosome indicate inflammation. Secretory IgA tells us about mucosal immune activity. And the short-chain fatty acids reflect microbial fermentation. And finally, the stool pH helps to identify whether the environment is too acidic, which we often see with loose stools and lactose intolerance, or if it's too alkaline, which we see with constipation. And then the subsequent commentary section is dynamic, and it's based on your patient's individual results. So you can see here, in this case, this patient's levels were low normal in yellow. So since the instructions say not to use laxatives because of how they can alter stool composition and the microbial profile, some safer alternatives are magnesium citrate, psyllium husk, and oral fleet. And one of the reasons, or some of the reasons for not using the over-the-counter preparations of laxatives is they tend to have a waxy substance, which can persist in the stool for a week or two, and that's going to impact results. This is another concern that we often hear because approximately 10% of the US population is on protein pump inhibitors. PPIs aren't specifically contraindicated, but they can shift the pH and microbiome patterns. So we prefer that patients stop them whenever possible. Also note that long-term PPI use is associated with C. diff, as well as associated with B12, and magnesium deficiency. And you'll see at gi360.com, there is a treasure trove of information to guide your gut health journey. And here are some more resources for you to learn more about our GI360. So let's shift gears and talk about the cardiometabolic profile, which is a blood test. Yes, the test does include apolipoprotein B and fasting insulin, which are two of the most sensitive early markers that we have for cardiometabolic risk. ApoB tells us the number of atherogenic particles, and fasting insulin picks up insulin resistance years before glucose or A1C change. The profile also includes other important markers such as LDL-C, HDL-C, triglycerides, non-HDL cholesterol, hsCRP, lipoprotein(a), glucose, A1C, and HOMA-IR. So altogether, they're giving us a comprehensive look at early metabolic dysfunction, inflammation, dyslipidemia, particle burden, glycemic control, and cardiometabolic risk. All of this well before disease is actually going to present. So the big takeaway is that this panel provides a proactive early detection view of cardiometabolic health that goes far beyond a standard lipid panel, allowing us to identify at-risk patients early and to intervene effectively. The LDL subtypes that drive atherosclerosis are oxidized LDL, small dense LDL, and Lp(a). Oxidized LDL is a strong independent risk factor for cardiovascular disease, and it directly fuels atherogenesis and inflammation. Small dense LDL is more easily oxidized, and it's more atherogenic. And Lp(a) is genetically determined and significantly increases risk. These patterns are associated with myocardial infarction, angina, metabolic syndrome, and hypothyroidism, and they're worsened by trans fats, smoking, toxins, and oxidative stress. So we use the advanced lipid markers when standard lipid panels don't explain the risk, especially in patients with family history, or metabolic syndrome, or insulin resistance, or persistent inflammation. The panel is going to outperform a standard cholesterol test because it's going to measure that particle risk with ApoB, Lp(a), and small dense LDL, oxidative stress with oxidative LDL, and metabolic dysfunction with 1,5 and I've been practicing this one, 1,5-anhydroglucatol and adipoconines, as well as inflammation with Lp(PLA2, homocysteine, and hsCRP, all enabling you to get that early intervention. So now we're moving into metal testing. In this section, I will do a brief overview of the different collection types in blood, urine, stool, and hair, and what you can learn from each one. So blood is considered the standard of care. You can never go wrong with blood testing if you can't decide what you should start with. When we talk about testing for metals exposure, it's important to anchor it all to blood because blood is the standard of care and it reflects a 60 to 120-day exposure, especially for metals like lead, mercury, and arsenic, and it captures both extra and intracellular levels. So it's the most reliable choice whenever exposure or toxicity is suspected. From there, each additional test type answers a different question based on its timing window. So urine reflects current or ongoing exposure because it shows what the body is actively eliminating right now. It's useful when you want to understand present time excretion patterns or if you want to screen for metals that are going to clear quickly from the blood. Stool reflects exposure over the past 24 to 48 hours. So it's particularly tied to dietary and GI exposure, including mercury speciation. So it tells you what's passing through the gut or what's being excreted through bile. And hair shows long-term exposure up to 90 to 120 days. It's convenient, it's non-invasive, and it's helpful for seeing longer-term exposure trends, though it does not reflect the body burden or retention. Whole blood metals are the standard for diagnosing toxicity, especially lead, mercury, and arsenic, and for assessing recent or ongoing exposure. The blood testing captures both extracellular and intracellular levels, as discussed, giving that complete picture. It's also the safest and most appropriate test to run before starting and periodically during any detoxification therapy protocol. So this is just a summary of that previous slide. The hair element analysis is going to give us a temporal record of exposure because the hair grows about 1 to 2 centimeters per month. It reflects recent and ongoing exposure to metals like methylmercury and arsenic, and it can show time average trends in some nutrient elements. So you're seeing the toxins here and the nutrient elements down below. Hair can screen for recent or ongoing exposure, and it's helpful because it provides a temporal record and it's easy to collect. Even pubic hair can be used if scalp hair isn't available. So it's important to remember that hair is highly vulnerable to external contamination from shampoos, dyes, bleaches, and straightening treatments. So ruling out contamination is always going to be the very first interpretive step. Unlike blood or urine, hair cannot assess essential element status, and it doesn't reflect net retention, so it should always be interpreted in context. And so here is the resource guide for hair. Urine gives us 3 different options: essential elements, toxic metals, or a combined panel. It's excellent for assessing what the body is excreting. Interpretation is going to vary with collection method, but it remains one of the most clinically helpful ways to evaluate toxicant elimination. The 3 choices are random, timed, or 24-hour. Random is easy and it's great for screening. Timed collections are going to help to standardize output, especially for any kind of treatment protocols. And a true 24-hour gives the most comprehensive elimination picture. So the choice just ultimately depends on your clinical question. So the 2 tests can be ordered individually: toxic metals urine or essential elements urine, or that they can be ordered as one combined profile. And here is what the combined report looks like. You get a full picture of both the toxicant excretion on the left and the nutrition element output on the right, which can be crucial when toxicity and deficiency coexist because of the interference that metals are going to have with a lot of nutrient absorption. And here is the resource guide for urine. Stool metals are primarily reflecting ingested metals from food, water, supplements, and environmental exposures, and to a lesser degree, what's being eliminated through biliary excretion, which is a major detox route for mercury, cadmium, lead, antimony, and uranium. Studies performed at Doctors Data have shown a strong correlation between fecal mercury levels and the number of dental amalgams. So patients with several amalgams will often show higher fecal mercury than those without. So use stool when you suspect GI exposure sources or when you want to understand mercury speciation. It's also great for infants or patients with difficulty collecting hair, urine, or blood. And it's great for people who eat a lot of fish, or if they have GI symptoms, or if they're ingesting contaminants without realizing it, or if you suspect that they're ingesting contaminants. The fish is a really interesting piece of this puzzle too, unfortunately. So here is the resource guide for toxic metals. And this is a comparison chart of all the toxic and essential elements profiles, giving you an indication of what's being tested in each one and how they compare. And that QR code is going to give you some additional information as well. So there's a couple different ways that you can get your questions answered. We have clinical and educational support available all week long during business hours. You can call the 800 number, or you can email the staff doc's email address to get your questions answered. Or, this is very exciting, our latest addition is that we have an AI assistant, Dee Dee, and you can go to drsjada.com and you'll see in the lower right-hand corner the AI, our little AI, a little chat bot there, and you can ask the questions and you'd be surprised at how great the answers are. So oftentimes you don't even need to deal with a phone call or an email because you can just ask Dee Dee. So that is it for my presentation. And I am now happy to take a couple of questions.